Bismillahirrahmanirrahim. Assalamu alaikum, doctors. Myself, Akil Haider, working in Genix Pharma. On behalf of Genix, I welcome all of you. Let me introduce Genix to you. Genix was founded in 2004. Genix is being one of the fastest growing company in Pakistan. Our aim is to provide top quality medicine at affordable price. Today, our session is about educational activity, and the presentation topic is depression in elderly patient, presented by well-known consultant physician, Associate Professor Dr. Fatima Jehangir. Let me introduce Dr. Fatima Jehangir to you. Dr. Fatima Jehangir is head of the Department of Family Medicine in Ziauddin Medical University, Karachi. She is a very busy person, but always available for education. Thank you so much, ma'am, for your precious time. Uh, Dear doctor, if there is any question, please drop your question in question answer box. Question answer session will be after presentation. Over to you, ma'am.
Thank you so much. Thank you so much for the kind words. And I'll be delighted to talk about this topic, depression or dementia, and focus on the cognitive symptoms of depression. As we know that depression is so common here, the prevalence is increasing. We really do not know the exact data of our country, how much is the prevalence of depression in Pakistan, because the numbers that we know are for sure very low. Because in our clinics, in our day-to-day lives, we see almost more than 50% of them are depressed or have got some sort of cognitive decline. It could be anxiety related, it could be depression, and most of the times it is overlapping. So it is very important to at least identify the symptoms so that in our clinics we could be it will be helpful for us to diagnose the disease, because what happens with this patient is that he goes from doctor to doctor, because the symptoms, I'll be talking in detail in my presentation, the symptoms are very much physical, and there is cognitive decline who nobody appreciates, because we are not trained to appreciate that. Our tools, or the validated tools which are there, multiple tools, but those are not very specific in diagnosing the cognitive decline. So we need to appreciate, and our physicians who have more bonding with the patients, nobody goes to a psychiatrist right away, because people are actually in a phase of denial. They would never disclose that they are depressed. Nobody cries. Like men will never cry. Women, although, will cry right away if you just pinch their weakness. So the point what I'm trying to convey is that it is very much under recognized. So we need to, our primary care physicians, our family physicians need to know how to recognize such symptoms, because even the non-verbal cues, the patient won't be able to tell you. The non-verbal cues means that by looking at the patient, the point the patient enters your office, he comes to your room, you should be able to know whether he's accompanied by somebody, he is blank faces, he's not able to communicate well, not making eye contact. These are something that the physician needs to appreciate and acknowledge, because this will be helpful in making your management plan. So to diagnose with, my task today is to talk about depression in the elderly, which is very much under-recognized. We do not even appreciate the diagnosis depression, because we take it as a condition. We underestimate depression, because we think that everybody has it. But we need to know that there are many differentials. It could be delirium, and an elderly person especially could be in a delirium, which happens after an acute illness. It could be an UTI, it could be pneumonias, or it could be due to any electrolyte abnormalities. Some elderly people losing their teeth, they are not able to take nutrition well, and that could lead to hyponatremia, hypokalemia, and then later on delirium. So people will think, people around them who do not have any clue what depression is would say, or the family members would say that it is the person has gone out, he's become stubborn, he is not like himself. So we lose respect for this elderly person who is so graceful, so innocent, and who doesn't know, who is just manifesting his psychological problem in his physical manifestations. So we need to understand and recognize and tell the attendants or the family members that this patient is going through depression, and the symptoms of depression are manifested in such manner. Then there is dementia, which happens in elderly. Dementia there is slow cognitive decline. The patient would be forgetful and will be repeating himself on and off, and that also becomes very troublesome for the caregivers. There is a caregiver burden. We do not realize that, because one person affected, the whole family is affected. The whole family has to take care of this person. There will be an impact in each and every individual of the family, may it be a child, may it be other people. So because when we lose, when you're not able to go to work, you lose your functionality, and that is because of somebody else. So if we appreciate depression early, delirium or dementia, and we take correct measures to correct it and make a plan to manage it, there will be less caregiver burden and less morbidity. So depression in the elderly or late life depression is a heterogeneous disorder. It is very tricky to diagnose. It is because it is manifested with physical symptoms more. Broadly, it is defined as depression in adults more than or equal to 60 years of age. And it could be classified as somebody who has new onset depression after 60 years of age, or somebody who has depression in early life and has a relapse of it. So how common is it? Data says 15 to 20%, but I think that it is much, much above that. Among elderly in Asia, prevalence rate of depression disorders vary from 10 to 20%. They say 13% in China, 13 to 25% in India. I think the real world scenario could be probably 3 times more than that. Because with comorbid, if we evaluate other conditions like diabetes, we know that 60% of all diabetics are depressed. So diabetes prevalence is increasing. So why not depression? So the known figures that we have are not the true representation of our society. Asia's elderly account for 58% of world's elder population, and only 1/3 of elderly depressed are formally diagnosed and treated. So the dilemma is that we are not appreciating or acknowledging the disease, and that is why nobody even realizes that one needs to seek a physician's expert opinion. Then what happens? Most of the time we consider it. Why do we not recognize it, or it is underestimated? Because we think that it is normal aging. With aging, pains and aches will happen. With aging, one will become forgetful, one will not be able to concentrate, and there are sleep problems and appetite problems and much more. So we consider it as normal aging process. Coexistence with other medical and neurological conditions, and yes, but it is very difficult to appreciate, because medical illness, as I said, UTIs, pneumonias, other infections, electrolyte abnormalities would lead to delirium and psychological problems, and neurological conditions also, like dementia and normal pressure hydrocephalus, many more. Somatic explanation of complaints: patient would be more fatigued, would present with early lethargy, fatigue, and pains and aches, and that is difficult to diagnose. Presentation is frequently atypical or subthreshold. Most of the times it is difficult to diagnose, and very fewer times the elderly person would be very sure and tell you directly that yes, he is depressed, he has low mood, he has lost interest in daily activities. But most of the time it is not the case. Most of the time you are unable to represent your true self, and then it is the job is the physician's job to diagnose it. So how is it presented? With anxiety. Anxiety presents with fear of the unknowns. You don't really know for sure what you're worried of. You are worried of your children's problems, your families is expanding and engaging into more activities, your grandchildren. So there is not one thing that you can think of. Your children and grandchildren are going into universities, their relationship problems, their job problems. So much to think. So this elderly person thinks that he's the head of the house and he has to take care of everything. So there are the anxiety problems, and he's anxious of such worries. Cognitive dysfunction. Again, this is a big big thing that is very difficult to diagnose, and my focus of presentation would be on cognitive decline. Then somatization is the unexplained pain. Your pain is, your body is telling that you're having psychological problems. Somatization, you might have tension type headaches, you might have cervical problems, you might have lower back pains, neurological problems, and radiculopathies and neuropathies, and you will go doctor to doctor with this thick file and nothing in hand, everything coming normal, and you're treating with B12, you're treating with neuropathy, and nobody recognizing that it is the repercussion of your psychological ailment. In behavioral problem, very difficult. People who are repeating, we have lost the threshold of understanding our elderly. Nobody has time actually. So no, our children do not have time even. So how would we expect ourselves to sit with the elderly, and they're repeating their old stories again and again, and we do not have the stamina to listen to them. So we need to understand this is part of their cognitive decline, and they will repeat themselves again and again. And we just sometimes become very rude, and when we lack time to sit with them, we become rude and insult them. Deliberate self-harm, sub-intentional suicide. People, elderly, they do not eat, thinking that why would they eat? What is the goal of their life? They lose interest. So it will result in self-harm. Late onset, alcohol dependency or substance abuse, that is also seen. And what are the challenges? Cognitive impairment can be diffuse, as I said, diffuse in depression, not particular thing, not just physical, not just psychological, it would be more cognitive decline also. Symptoms and test performance are heterogeneous. So again, no homogeneity in their problems. Some people will say they are feeling low. Some people will say they've lost interest in activities. So different manifestation. And pattern of dysfunction can be unclear and incoherent. Elderly people they will present with vague symptoms. Some people will say that they're not themselves. They are not their usual selves. And that is enough to think that yes, that there is something wrong and we need to address that. Comorbidities can affect cognitive decline. Obviously, this elderly person has been suffering from a lot of physical ailments, diabetes, hypertension, dyslipidemia, uric acid problems, and whatnot. Osteoarthritis knees and arthritis, nodal osteoarthritis. And there are so many other problems, that lifelong problems that add to the comorbidity and then leading to depression. So this slide is very important and if you understand this slide, you think this will convey my message. So just to go through this, to revisit what emotional symptoms a patient presents with, and mostly our questionnaires represent only these emotional symptoms. Sadness. So PHQ 9 questionnaire says that, and if for the past 2 weeks, if you've got most of the time, if you're suffering from 5 out of 9 symptoms, you fit under that criteria, and that would be sadness, anxiety. There is anhedonia, loss of interest in daily activities, low mood, sleep problems, and you're not concentrating well, and you have guilt and all sort of hopelessness, worries, and your appetite either decreases or increases. There could be weight loss or weight gain, and then psychomotor retardation. You either become slow in your mobility or your speech, your speed of speech, and then there could be atypical depression also, in which you're actually fidgety and restless and agitated and whatever. You'll have angry outbursts. That is atypical depression. So all these spectrum of physical manifestations will be there. Then physically you will feel fatigued, eating and weight changes, insomnia, and sexual problems. People do not disclose it very often. Psychomotor agitation, you're becoming more restless. You're not able to sit in your chair for a long period of time because something is bothering here and presenting like this. Pains and aches, your threshold for pain is low. You have all sort of illnesses like fibromyalgias and chronic fatigues and some stomach problems. you know, and we have seen that there's a you can say a wire or a cable attached here from your tummy. It's that whenever you're depressed or anxious, some people present with depression or abdominal cramps. So actually, we have been able to appreciate functional dyspepsia and irritable bowel more in this COVID era, because we think that depression is overall increased, and there's this problem there, stomach problems have increased. Even young people present with functional dyspepsia, early satiety, bloating, and then there is Romford criteria, which is there to diagnose, but people do not appreciate that. So this is all linked. Then coming to the cognitive, this is very difficult and the most difficult to identify and even appreciate. When the patient says he is losing attention span, and concentration, you are not able. When you're reading a newspaper, you're watching your drama, your movie, you're not able to concentrate on your simple tasks. Short and long-term memory. Usually people lose the short-term memory first. They're not able to recognize names and faces. And then later on the first anterograde amnesia and then retrograde amnesia. Then the decision-making, they're not themselves. They're not able to make quick decisions that they were able to make earlier. Then planning and organization skills. This is very important, and people would not appreciate in real sense what I mean by that. Planning and organization, that you always, one human being always has to flourish and to go ahead, and it's just not a CEO of a company would think of such things. Organization planning, strategic planning is everybody's task. Everybody has to plan. Either it could be your office-based business, or it could be your home tasks, your home-based tasks. You need to plan when to go, when to send your children to work, to school, what to think 5 years ahead, think 10 years ahead, what lies ahead, what problems you need to sort out right away in order to reduce problems later on. And mental sharpness, you're presenting with vague symptoms. Your thinking speed is low. Your judgment capability is low. You're not able to judge well. You're not able to think well. This is very difficult, and even trained physicians might take time to diagnose whether your patient is having such problems or not. And many times we do not have time to sit with them and try to identify this all a spectrum of problems that is there. Nobody has. No family physician, no psychiatrist would have enough time, because the prevalence is so much and time is less. How would we be able to judge whether a patient is suffering from all this or not? So again, in a nutshell, it is all what I have talked about: behavioral problems, reduced activity, withdrawn and isolated, and loss of behavioral function. And keep in mind that it is not it is very easy to label depression, and such patients who have organic problems might fit into such psychological disorders diagnosis also. But we need to think like common symptoms first. We need to rule out anemia. We need to rule out hypothyroidism or hyperthyroidism, in which person would become fidgety and restless and losing weight and such things. So go for your CBC, look at the hemoglobin levels, correct your anemias, and look at the TSH, and you can correct that. And then look at the medication. Medication review is a must. You need to see whether some problem, some medication that is causing such behavioral issues. And then look at the electrolytes. Some metabolic disorders could lead to this. So when you rule out all these problems, and then you have to keep in mind that this could be psychological. Cognitive and emotional problems, feelings of guilt, thinking slowly, concentration and memory problems. So everybody is different. No human being is alike. So everybody has different speed of speech. I might be very fast. In my people, you say that your speech is that like whatever is my speed of speech. If I'm depressed, my speed of speech will become low. So you have to relate it with what was your normal. Hopelessness and suicidal thoughts. And if there were any suicidal thoughts, then whether a plan has been made, an attempt has been done. if the plan had been made, then to what extent, if it was successful or not. So you have to identify all this. Sad mood, anxiety and worry, loss of interest and enjoyment. Enjoyment, happiness is the key. We are losing interest and we are losing our happiness. We are just going with the flow. We are not enjoying a child playing. One should enjoy going out and playing and looking at the nature should give you happiness feelings. But we are losing as a community. We are not able to judge the happiness. You are not able to judge the beauty of the nature, and becoming depressed as such. Physical symptoms of early fatigability, poor energy, sleep problems, appetite and weight changes. We become couch potato. Even if we have any depressing day, we would eat more, because we do not have any discipline in life. We exercise less, and we think that this is the remedy. Eating more, being couch potatoes, this is the remedy. Slowing down and agitation and pains and aches, like it will present with mostly tension type headaches and cervical pains. All of this impacts on the functioning. Your functionality is affected with all of this. The key is to determine all this. So attention, domains of cognition would be attention, the ability to focus and sustain attention. Even if you're able to focus, you lose your focus very soon. Memory and learning, including episodic memory relating to the past or future events. And you forget. Verbal memory, learning, and visuospatial memory and learning. Where did you put the keys? And you're so lost that you might put the essential keys in the fridge. You might put it here and there and you forget. Then executive functioning, ability to monitor and regulate cognitive processes, employing attention, planning, working memory, mental flexibility, inhibitions, task initiation and monitoring, multitasking. One should be able to think of more tasks than the one that you are focusing. But a depressed person would not be able to do that with justice. And decision-making capability would be lesser. And psychomotor speed, the speed at which the brain controls the body to perform physical tasks, you become slow at that. So here I'm going to see the dark blue are the attention, memory, executive function, psychomotor speed would be judged by the physician. And the orange ones are the real-time terminology, real life terminology. And the light blue ones are the patient descriptors. Patient will tell you that there's lack of focus. I'm not able to focus well in whatever I'm doing. Concentration difficulties, and I'm not able to listen well and judge well. Losing train of thoughts. You think of one thing and then you're not able to focus on it for long, and then you're jumping to another tasks. Then attention deficit. So this is all the patient is telling you that. Back of the mind, the physician should know that this is attention loss. Then if the patient says that he has lost short and long-term memory or become forgetful, you have to think of first, rule out dementia, rule out delirium and organic pathologies, and then you think that there is memory loss due to psychological problems. Then indecisiveness. How would it present? With procrastinate. You will think, no, not today, tomorrow. I cannot handle this problem today, and I will probably tomorrow, probably day after, probably next week, next month. And you are procrastinating and not fit to think of it and take it this problem right away. Lacking confidence. You are not able to face people. Phobias, and you're not you're losing interest, you're losing confidence in yourself and your capabilities. Indecisiveness. You will be confused in what decision to make. So this the doctor would be able to appreciate that this, if your patient is complaining of such complaints, this is executive function loss. And then slow processing. Brain is cloudy, slow motion, tired and lethargic. You're slow, you're not able to do anything. And that is the slow processing. And that physician should be able to judge that your psychomotor speed is you're losing your psychomotor speed. So these are all areas of cognitive decline. So what were what we had, the drugs that we had to combat it, monoamines, glutamate and GABA are involved in both depression and cognition. Hippocampal atrophy is seen in depression. To this day and age, we do not have any investigational modality, no CBC, no ESR, no investigation would in black and white would tell you that this is depression. Neither any imaging. You go for any scan, no MRI, no PET scan, no CT scan would tell you that the patient is depressed. So it is very difficult. We hope that probably in our children's era, probably they should come some modality that would be able to judge your dopamine levels or your serotonin levels or norepinephrine levels, which we are just talking about it theoretically, but we do not have any investigation modality that can tell you for sure that it is depression. So multimodal is the pathophysiology, and we need to have newer drugs that are multimodal and that could impact on cognitive decline also. So if we see here, mild cognitive decline could be there, sleep disorder, brain trauma, comorbidities like obesity and diabetes. Again, we have data to say for sure that comorbid conditions are associated with depression. Side effects of psychotropic medications, for example, somebody taking mood stabilizers like olanzapine, aripiprazole, and especially the first generation psychotropics, haloperidol, such medications present with, they have side effects of akathisias. You're restless, fidgety. So you have to think of those. Medication could be a cause. Substance abuse. We know for sure that people who are depressed and having psychological ailments, we have data to say that even schizophrenics are more vulnerable to substance abuse, heroin, chars. This is very common in our part of the world even. Alcohol as well. Age associated with cognitive decline. With time, you think that it is age related cognitive decline, but it is actually your functional decline due to depression. Dementing disorder like vascular and Alzheimer's disease, Alzheimer's senile dementia. So we should be able to appreciate what are the markers of dementia and how do you differentiate it from overt depression. So multiple scales, the validated tools are there, Montgomery, Asberg scale, and Hamilton depression scale, and PHQ-9 questionnaire. So in which you can see that they focus more on the emotional problems, and they're not good tools to judge the cognitive symptoms. So emotional symptoms, again, sadness, lack of enjoyment, anxiety, and hopelessness. Physical symptoms, eating problems, sleep problems, and somatic problems, and fatigability, losing energy. They can judge these well, physical and emotional problems, but they cannot judge this. This domain is very much unrecognized with these very well-known, widely practiced tools also. The difficulty concentrating, indecisiveness, and forgetfulness is not judged very well with such rampantly used scales. So Hamdi scale for assessing cognitive dysfunction, very less, not very specific for diagnosing cognitive decline. It says retardation, slowness of thought and speech, impaired ability to concentrate. Then Montgomery Asberg's depression scale, difficulty in concentrating and sustaining thought. You're not able to linger on with one thought. Your mind will go places to places, and there is attention deficit. Then PHQ-9 questionnaire, trouble concentrating on things such as reading a newspaper or watching TV. So routine activities, you're not able to concentrate in well. So none of these validated tools are judging your cognitive decline. So these standard depression scales do not assess the cognitive decline. So here comes your mini mental state exam, which is there to diagnose dementia. More than 30 is the denominator, and if 22 or less, that means it is your patient is having dementia. So how do you judge it? In your primary care facility, if you have less time, you can also go with the mini cog tool. But the full-fledged scale is the mini mental state examination, in which you will just go through it very quickly. 5 points in which you need to identify what year it is, season it is, date, day, month. You give 5 points if your patient is able to tell you all this. Then which state it is, country, town, hospital, and your floor, If the patient is able to tell, then you give 5 points for that. That makes 10. Then you make the patient remember, just recall first any 3 items, like it could be a table, it could be a chair, or a fan. So just try to make your patient recall that. If the patient is recalling, give 3 points, and tell this patient that after 5 minutes I'll be asking you to recall those. If after 5 minutes, if the patient is able to recall, you give 3 more points to him. Then you ask the patient to spell back the word world, W-O-R-L-D. The patient is able to spell it back, D-L-R-O-W, so that you give 5 points to that. Then again, language problem, you give 3, you give a command, ask the patient to follow it, make a picture. If the patient is able to do it, you give points. So 22 and less out of 30 makes your patient dementic. So now coming to the geriatric depression scale. So this is very thorough. And if you go through this, I think everybody will fit in it. So it is very important to judge very well that how do you go about it. But when you know, you'll think about it. So what are the symptoms? You have to ask your patient, are you basically satisfied with your life or not? Or you think that you are a failure or a loser? Have you dropped many of your activities and interests? Earlier, you used to do biking, you used to go outside, you used to meet your relatives and friends. Now you're not doing that. Do you feel that your life has become empty? It was full. It was too much to do in life. Now you think that you're not doing well. Do you often get bored? Your family members, your children, grandchildren are engaged in their activities, and you're bored and you have nothing to do. Are you hopeful about the future? If you have many concerns about future or not? Are you bothered by thoughts you can't get out of your head? You're too big all the time. You're worried of same things, simple things like the maid hasn't come, this and that, room cleaning. People are so obsessed about this that they're not able to do executive function. They're not able to think out of it. Are you in good spirits most of the time? So you are happy, you're smiling or not, or you're all the time sad and not happy? Do you feel helpless? You think that at the time there will be nobody to help you out? Do you often get restless and fidgety? That is a marker of atypical depression. Do you prefer to stay at home rather than go out and do things? This patient will say no whenever you are going out. He'll stay at home and rather stay all alone by himself. Do you frequently worry about the future? This patient will have all sorts of worries, even for simple things. Do you feel you have more problems with memory than most? He'll be forgetful, keeping things, simple things here and there. Do you think it is wonderful to be alive now? This patient will be hopeless and will have no purpose in life. Happiness, you cannot pursue happiness. You have to pursue your purpose. And purpose could be anything. It could be your, like, if I'm seeing patients, my purpose in life is like teaching, seeing patients, and this and that. But for a household lady, a stay-at-home woman, taking care of the family would be the purpose of her life. And if she is not able to function that purpose life, she will lose interest and she won't be happy. So do you feel that is wonderful to be alive or not? Do you feel downhearted and blue? Do you feel pretty worthless? Do you worry a lot? You find your life less exciting? It is hard to get started on new projects. You will procrastinate and you will not be ready to think of new avenues in your life. Do you feel full of energy or not? Do you feel that your situation is hopeless and there is no remedy to it? People come to us and they'll think, no, mere problem ka to koi hal hi nahi hai. They will say that, yes, I cannot handle this anymore. Do you think that most people are better off than you? You will always underestimate yourself and you'll see everybody is better than yourself. Do you frequently get upset over little things? Do you frequently feel like crying, trouble concentrating? Getting up in the morning, when you get up in the morning, you should actually, your headaches should get relieved. But this patient will be having headaches in the morning as well. Will have a sad face in the morning as well. Do you prefer to avoid social occasions? Is it easy for you to make decisions? Is your mind clear as it used to be? So you have to relate it from your previous self in all these questions. Conclusion or take-home message would be your cognitive impairment and depression can be diffuse, difficult to diagnose, symptoms and test performance are heterogeneous, and the pattern of dysfunction can be unclear or incoherent. This patient is not able to convey very well whatever he is feeling. You have to diagnose it. You have to probe and pull out what your patient really wants to tell you. It is necessary to know the clinical evidence and the tools available to recognize, measure, and differentiate cognitive dysfunction due to depression. But be very careful, diagnose anemia, thyroid problems before that, and electrolyte problems, any concussion, anything that, and then label somebody depressed. Diagnosis workup allows differentiation of cognitive symptoms due to depression from other possible causes, as I just said. Sometimes in this clinical case, differential diagnosis is very early. In very early dementia must be clarified. It could be new onset dementia. The patient might be declining. So it is not one session that tells out everything. Multiple sessions will lead out, and your physician-patient bonding will be more, and you will be able to judge the cognitive decline also. So this treating geriatric patients, this geriatric patient, as I said, may experience disproportionate injury from psychotropic medications on account of increased frequency of use, altered pharmacokinetics, and slower metabolic clearance. So the dilemma is that whatever we had in our market earlier, it is causing a lot of problems. So that depressed patients is already giving you a sack of problems. And then these medications will add to it. You have sleep problems, you have weight problems and sexual dysfunction and whatnot. So you're not able to tolerate the medications well. So you're there and again, they're back to scratch. So what to do? And the comorbid illnesses are adding to the problems. Comorbid illnesses, like for example, heart problems, you have to, like arrhythmias, you have to think of lesser medications. You have to think of medication that are arrhythmia friendly. So we have seen that earlier we had TCAs, imipramine, and then we had SSRIs came in the market in 1982, then SNRIs, and then agomelatine was approved. Then newer drugs was approved by FDA, vilazodone, and the newer agent that has come in the market is FDA approved, which is Vortioxetine, which is multimodal. And we know that it is acting on multiple receptors, just not serotonin. When we look at the side effects of the medication that we had in hand, fluoxetine, sertraline, paroxetine, fluvoxamine, citalopram, escitalopram, the SSRIs do present with GI problems, sexual dysfunctions, insomnia, migraines, weight problems, and potential for serotonin syndrome. SNRIs like venlafaxine, desvenlafaxine, duloxetine again presents with all such problems. TCA presents with cardiovascular issues and arrhythmias. Already elderly patient might be having cognitive decline and constipation. So the TCAs add to arrhythmias and orthostatic hypotension, dry mouth, sexual dysfunction, tachycardia, impairment, and more constipation and cognitive decline. So this class of drugs adds on to your what problems you actually present with. Then MAOIs, phenelzine, and such drugs, selegiline, cause hypertensive crisis. We do not really use them rampantly. Then your miscellaneous drugs like bupropion, mirtazapine, agomelatine also have side effects. So the newer drug, vortioxetine and vilazodone, might cause nausea and nausea, vomiting, and diarrhea also. So there is need of a newer agent who would have lesser side effects, lesser cardiac threat, potential cardiac threat, and low remission rates, persistent symptoms in those who do respond, and lesser side effects. Lesser side effects of weight gain, sexual dysfunction, insomnia, and GI problems would have lesser impact on the sleep and cognitive decline. And low relapse. We know that we see people with relapse. At some point in time, this patient might be having depression earlier in life, and you need to see, first of all, whenever you give a antidepressant, you need to know whether this is unipolar depression or not. Somebody having bipolar depression in a currently in the depression phase, and you might write a antidepressant and this patient will go into mania or hypomania if he is bipolar. So you need to be very sure that this is unipolar. So bipolar in depression phase, you have to give a mood stabilizer along with depression antidepressant pill. So we need newer efficacious antidepressants for the treatment of major depression episodes having good tolerability profile with additional benefits in the cognitive symptoms of depression, which earlier medications did not address. So your choice of antidepressant would include your tolerability, safety, side effects, drug interactions, contraindications. Use medications with minimal anticholinergic. The elderly usually have retention, urinary retention. So if you write such drugs that might cause more retention and glaucoma, angle closure glaucoma, cardiovascular effect and orthostatic effect. So start slow with such drugs, vortioxetine even, and then up titrate. Monitor compliance, make sure this does not have any interactions and lesser impact on sleep and concomitant illnesses. So in conclusion, late life depression tends to be under-recognized and under-treated. Choice of antidepressant in the elderly, you must think of tolerability profile, safety profile, side effects, drug interactions, concomitant medical illnesses are issues to consider. And if you have such problems, start low and then up titrate to the optimal dose. While SSRIs have been considered first line, vortioxetine is poised as an effective treatment for late life depression. You may give it early, you may give it later on, but this will improve the cognitive decline also. Favorable cognitive effect profile, lack of sedation, lack of changes in the body weight, and ECG parameters may be particularly advantageous in elderly depressed patients. So here, if we compare vortioxetine 10 and 20 milligram with the agomelatine, you can see that after 12 weeks, you can see that if you follow the Montgomery-Asberg depression score, you can see that there is a major benefit with vortioxetine as compared to the agomelatine. Then here, if you follow the Hamilton depression score in the elderly above 65 years of age, if you give, you're comparing here placebo, vortioxetine, and duloxetine 60 milligram. So vortioxetine 5 milligram, you can see improves the depression scores, the Hamilton depression score if we follow, as compared to placebo, which is the lowest, and then the duloxetine, and then your vortioxetine helps more. This in a nutshell tells you all about prolonging the QT interval, arrhythmias, conduction problems, and as compared to other if we just point out a few, like TCAs, increases in heart rate, causes postural hypotension, prolongs the QT interval, can cause arrhythmias, ventricular arrhythmias. So safety profile is not good. Similarly with the SSRIs and other SNRIs. So here, if we compare with vortioxetine, lesser side effects. These are the side effects: dry mouth, diarrhea, constipation, sweating, fatigue. Lesser side effects observed. So emotional blunting is a common but difficult to treat problem. So SSRIs are effective for treating mood symptoms. However, patients often describe feeling flat upon recovery. They do not see major recovery to their original self. So you need to see whether if the patient was able to go to work, now not going to work. So you need to see the goal is go to work well and making good decisions there, being able to concentrate there. So if the patient is able to reach the goal, that is your recovery. That is considered recovery. So there is a lot of apathy, inability to cry, narrowing of emotions in 46% of patients. So emotional blunting, as I've explained very well, inability to cry, feeling indifferent, less able to laugh or cry, feeling reduced social responsibility, higher risk of relapse. This patient will have relapsing episodes of depression multiple times during life, and loss of inspiration or passion or creative activities. This patient will not be able to be very creative or think out of the box. and feeling less empathy for others. You won't be able to judge others' feelings well. So emotional blunting is a burdensome problem for the patient and negatively affects the health of the patient, and it affects the functionality. So with vortioxetine 10 to 20 milligram, it effectively improves emotional blunting, overall functioning, motivation, and energy, cognitive performance as compared to the conventional drugs that we have in market. In summary, adult patients with major depression can start on Rontil 5 milligram once daily. Rontil can be increased or decreased. You start with 5 milligram and then you up titrate and reach to 20 milligram if needed, depending on the individual's patient's response. Rontil can be stopped without the need for gradual dose reduction, can be stopped abruptly if you want to. For patients age 65 years or older, starting dose of 5 milligram is good, and then you up titrate. It can be taken with food, without food. And no dose adjustments with mild renal and hepatic impairment. And if anybody wants to switch it with other medications, somebody taking SSRIs and you want to switch it, so what you do, you just not stop right away. You have to lower down the dose, like lower down the dose and start on with vortioxetine, and then increase the dose of vortioxetine, and thereby decreasing the dose of the other drug that the patient is taking. Till in 2 weeks' time, you have to make the switch, and then the patient would be able to continue with vortioxetine and then up titrate. Thank you so much. With this, I end my presentation, and I hope I am able to convey my message, and I am ready to take your questions.
Madam, thank you so much. Very interesting and very informative session. We have 9 to 10 questions here from audience. I will ask one by one. Madam, Dr. Saima from Islamabad wants to know if there is excessive nausea with antidepressant, what to do?
See, you have to measure the pros and cons, the risks versus benefit. If you think that, I would think for my patient, if somebody is having just nausea and not getting all the other problems that I'm more worried of, weight problems and sexual dysfunction, so I'll be happy with handling nausea. I can prescribe medicine to handle that. I won't let this patient be depressed and be off medications. So just give medications which have lesser side effects, and if the nausea can be taken care of. So do not leave this patient helpless, and treat it with your PPIs, treat it with your H2 blockers and antacids. And this patient should be started with antidepressants if this patient fulfills the depression criteria.
Okay. Madam, second question is from Dr. Wasim Rawalpindi. He wants to know the exact duration of the treatment of depression in elderly patients. How long we can use the antidepressant in elderly patients?
Very good question. And this is a problem that we do not know how long to give the problem. Most of the how long to give the medications. Most of the patients stop it for some or the other reason. We need to see that when you have to convince the patient that this is a long-term medication. 6 months you have to give by hook or by crook. It's just that 3 months more to it. Whenever you feel you are on top of the world, you are able to go back to your functionality level, and then give 3 months more to it. So if your patient is achieving that functionality in 3 months' time, give 3 months more. If your patient is able to achieve that in 6 months' time, give 3 months more to it. Same goes with the elderly. Elderly, we are not able to handle their relapsing episode. So better give it for a long period of time, 6 months, 9 months, 1 year, more, doesn't matter. Do not stop right away. You have to tell your patient that minor side effects can be handled, longer duration.
Okay. Madam, another question is importance of early diagnosis of depression. Is there any importance, or just like the diabetes or other diseases, doctors want to know, is there any significance of early diagnosis?
Yes, why not? When we, like, family physicians would be able to diagnose early. I don't think psychiatrists would be able to diagnose very early, because the patient does not go to their office right away. Our community is seen by a family physician first, and family physician will be able to judge it early. And that is why a family medicine history is not complete without psychosocial history. So whatever, even the patient is coming with lower back pain or migraine headaches or tension type headaches, you have to judge put forward the PHQ-2 questionnaire and anhedonia and feeling low. If your patient is saying yes to any one of the questions, you have to put forward the PHQ-9 questionnaire. So judge it early. We have evidence that diabetes, most of diabetics are depressed. Comorbidities, people are depressed. So judge it early so that you are able to diagnose. Like, for example, uncontrolled diabetes patient who comes to me and has psychological issues, I will choose a drug that will handle the depression as well as the neuropathy of depression, the neuropathy of the diabetes. So your management will be better if you diagnose it early.
Okay. Madam, one interesting question is there. If patient is not suicidal, it's difficult to diagnose because of the age factor symptoms combines together. Audience want to know, is there any special skill to diagnose?
What, could you repeat the question? What?
Madam, if patient is not suicidal, it's difficult to diagnose because of the aging factor comes in play, because of the people thinks that this is the aging factor. Is there any special scale to differentiate between that thing? He wants to know in elderly.
What I get out of this question, that it is very difficult to identify the suicidal ideation in elderly. It is difficult to identify suicide. Nobody will tell you. If somebody is planning, they might hide. So if you look at the PHQ-9 questionnaire, the suicidal ideation point comes at the end. There are multiple other factors that will lead you to the diagnosis. You ask in the end if your patient is ready to disclose whether the patient has made any attempt or thinking of it. So there are other parameters to judge it also. So in the end, you will ask, and you won't ask right away, like, do you feel that you are killing yourself? Don't be so blunt in asking that. Ask it indirectly. You may ask that, okay, do you think that with all these problems, to be very empathetic, ask that, okay, I understand all your problems, and with these problems, do you think that life is not worthwhile? You're not, you do not think of, you want to feel that life should end. So in indirect manner, you can judge a suicidal ideation. I know it, I understand it is very difficult to judge it, and you cannot right away ask it directly.
Okay. Madam, last question is about the switching. Our audience want to know, before switching, if a patient is taking an antidepressant, how long we can give before switching to another antidepressant? How much time we can give it to one antidepressant to work?
Right. So if you plan to for the problems, some bothersome side effects, if you are planning to switch from conventional drugs to Vortioxetine, the switch plan is like 2 weeks. In 2 weeks, you can taper down the conventional medicine, and bring up the Vortioxetine in a lower dosage, 5 milligram. And then in 2 weeks' time, you have to, like, for example, if you're giving sertraline 50 milligram, so you lower it down to 25 milligram and keep a 5 milligram Vortioxetine 1 week. Next week, you keep it to a half dosage, half of 25 milligram of sertraline, and then you are switching to Vortioxetine, up titrate Vortioxetine to 10 milligram. So 2 weeks time, you stop sertraline altogether and keep on the optimal dosage or whatever dose you want to keep with Vortioxetine, and then up titrate. This is the way you handle the switch.
Madam, thank you so much for your kind time. It was very informative and a very interactive session. Once again, on behalf of Genix Pharma, I thank you. And I thank all of the attendees also.
Thank you.